Muy buenas. Vamos a comenzar esta sesión que lleva por título How to Sessions in Atrial Fibrillation. That means that the session is going to be in English. So please, I would ask everybody to sit down and be prepared for the session, because actually our first speaker today, Dr. Mattias Duytschaever, is not going to be present here because he couldn't come because of logistic reasons in terms of airport transportation. So because of that, he's going to deliver his talk by internet, and I hope and we hope that everybody would be able to listen to him, to hear what he says, and to see his slides. One more thing is that the discussion after his talk is going to happen exactly after his talk, but not on the end of the session. And because of that, I would like to ask now Dr. Mattias Duytschaever if we can see him and if we can see his slides. Hello, Mattias, can you hear us?
Hello, I can hear you.
Perfect. Good morning.
Okay, that's great. Good morning, everybody. Can you see my slides?
Well, we can see you. And
Okay.
if there's a slide, yeah, if that's a slide, we can see your slide. And here on this side, I'm Jesús Almendral, and my co-chairman here, Vicente Bertomeu, and we hear you, and the audience is hearing you as well.
So I'm just going to do one check. If I go to the next slide, do you see then the second slide?
No, we see only the first one. Now we see.
Now?
Yeah, now we see your second slide. Yeah, perfect.
Okay.
Perfect.
Okay, vale. Okay, good morning, good afternoon, everybody. First of all, my apologies, because it was really impossible. It's not my rule not to come, but the flights were unreliable. So we did a lot of work today to set up the communication, and I hope you have a nice view on the slides. And we will let the slides speak for themselves. How to achieve permanent PV disconnection with radiofrequency. And I think we need to go through a small introduction, and that is almost history of AFib ablation. It all started with non-irrigated point-by-point ablation. And we know that when we use non-irrigated point-by-point ablation, reconnection was observed in almost 80% of the veins, meaning that the durability at 3 months was almost only 20%. I want to go over together with you in the next 20 minutes over the next titles. First of all, what is the result of irrigated catheters? Number 2, the contact force catheters. And 3, the closed protocol. And each time I want to discuss the data on acute durability and on the freedom at 12 months. Let's start with the irrigated catheters. The irrigated catheters have an acute durability, meaning acute testing of PV isolation durability with adenosine of 66%. So acutely with irrigated catheters, non-contact force, 66% of the veins are proof to injection of adenosine. And there is always a striking similarity between acute durability and what actually happens when you follow up the patients. Freedom of atrial fibrillation at 12 months, single procedure freedom, is around 66% if you look at the IDE trial of Wilbur. And basically the Fire and Ice shows the same 65% single procedure freedom. So this is irrigated catheters. And the reason why freedom is only 65 or 66%, is that lots of these patients have reconnection of the PVs. That is the Achilles heel of irrigated ablation. And that led to many editorials with beautiful titles like The Elusive Goal of AFib Ablation, A Decade of Trying, etc., etc. Then the second generation contact force catheters, whether it is via fiber optics or via magnetic sensors, the contact force sensing technology was developed. And we know from the animal model that the higher the contact force for a given power, your lesion will be more outspoken. So that brings us to the era of contact force guided catheters. Now, what is the acute durability and what is the single procedure freedom? The acute durability, for me, it's clear as an operator, but it's also clear from the literature that the acute durability markedly increases when you use a contact force catheter. If you check the veins with adenosine, at the end of the procedure, acute durability is statistically higher than when you are using non-contact force catheters. This is a paper from Andrade and Makler from Canada. They are not the only ones showing that with contact force catheters, you improve acute durability. I let you read the slides, you see the references, you will see that each of these studies shows that the acute procedural durability is increased with contact force catheters. And this acute durability again seems paralleled by what matters for the patient, which is freedom of atrial fibrillation. I show you a slide from the results from Toulouse, Canada, pretty consistent. In red, the freedom of atrial fibrillation using a contact force catheter compared to black being single procedure freedom with irrigated non-contact force. Similar results after sub-analysis of the Smart Touch trial. If contact force was used reliably, freedom of atrial fibrillation was 81%. Similar results for the TOCA-STAR study, now published by Reddy and by Deepan Shah. Freedom of atrial fibrillation using a contact force catheter in an appropriate way, and it was defined as more than 10 grams, shows superior freedom of atrial fibrillation versus a control group. Meta-analysis recently published also shows that when you combine studies that compared contact force versus non-contact force, that there is an overall reduction in recurrence by 37%. The result is that compared to irrigated non-contact force technology, contact force technology not only increases the durability, but again is paralleled by a higher freedom of atrial fibrillation. I still believe we need more randomized controlled trials to prove this, but it's a good indicator. Now, this result alone is not enough because there are many caveats in using the contact force catheter as such and their target values. For example, if you read papers, some people suggest it should be 20-gram target. Well, that seems not correct because it suggests that at each site you should use 20 grams. That can be dangerous and it can lead to a lot of overshoot, especially if you would use this at the posterior wall. Terminology that I do not like is the FTI because it has been placed dogmatically in papers that you should reach an FTI of 400 grams per second. First of all, it's not individualized. I cannot imagine it should be an FTI at each site. And two, it does not take into account power. So it can lead to a lot of undershoot, especially, for example, at the anterior wall, but it can lead to overshoot at the posterior wall. And the third argument that we're not there yet is that we did not reach the 100% yet. Of course, I realize that some atrial fibrillation is non-PV mediated, so it can never be 100%. But I don't think we are ablating until we reach the bottom of the non-PV mediated AFib. That brings me to what we have been doing the last 1.5 years, which we call the closed protocol. What is the closed protocol? The closed protocol is our standard of care. You see circumferential ablation. It's a point-by-point approach. It's based upon contact force. But we use closely spaced lesions. We believe we deliver transmural lesions, and the lesions are close to the LAPV junction. So I do not claim wide circumferential ablation. Here you see the 3 ingredients of what I call the closed protocol. It's closely spaced, it's transmural, it's close to the LAPV junction. Here you can see the encirclement. Closely spaced means that we ablate with the maximal center-to-center distance of 6 millimeters. We think that Visitech and respiratory gating are essential and key to ablate according to the closed protocol. Transmurality is based upon the ablation index. I did hear the discussion with Dr. Merino and Dr. Sarkozy, and indeed I will present lesion index, ablation index. And close to the LAPV junction means that with my catheter I try to look for those sites where the atrium and the PV potentials do merge. How do we assess transmurality? It's Hiroshi Nakagawa that presented in animal work the predictive value of force power time index or ablation index. And the index is a formula taking into account contact force, power, and time. And there are exponents, A, B, C. And you should believe me that the index for power is much higher than the contact force. It's about 80% is contact force and 80% is power, my apologies, and about 20% is contact force. So there is a greater impact of power, and this is known in literature, that power is more determining than contact force per se. And when you look at this formula, by mathematical rules, this will follow this mono-exponential curve, and this is typically a graph that reflects the thermodynamics of a ref lesion. Whereas FTI suggests you have a linear lesion, FPTI will describe this mono-exponential curve. Now, what is very important is that in the animal model, the formula predicted lesion depth quite accurately compared to actual lesion depth. But still, it's a big step from this formula, from the animal model, from the ventricle, to a patient with atrial fibrillation. So just accepting the formula was not enough. Now, what we did is there were, at a certain point in time, contact force guided ablations in our lab, in which the index was already available, but we were blinded to the results. So these results reflect patients ablated with contact force, with the index blinded. And what we did is when the patients were seen back, or when we had an acute gap during adenosine, or a late gap reconnection during a repeat, we could compare the values of index and interlesion distance and compare this in between segments with a gap and no gap. So we did careful analysis of segments and careful analysis of ref characteristics. And this is an important slide because, again, the animal model alone would not have been enough. What we did is we compared ablation index in a segment and we compared segments with a gap versus segments without a gap. And you can see that the values are lower in segments with a gap. In red, you see the values for the anterior wall, and in pink, you see the values for the posterior wall. So what you can appreciate is that if you would ablate with the value of 500 and more at the anterior wall, it would be very difficult to find a gap. If you ablate with 400 on the posterior wall, the likelihood of having a gap is really low. So that is how we come up with the index thresholds. For the interlesion distance, we did exactly the same. And what you can see in segments with a gap, acute or late, the interlesion distance is larger than in segments without a gap. And you can appreciate that if you would draw a horizontal line here at 6 millimeter, and then you have to go down, it would be very unlikely to see a gap. So these are the criteria we use. We use 400 index for the posterior wall, 550 for the anterior wall, and 6 millimeter similar for posterior and anterior wall. Are we the only ones claiming that continuity is important? Because basically, one of the new ingredients for me for the closed protocol is continuity, continuity, continuity. No, the answer is no. 3 papers, and probably more, already indicated that interlesion distance and achieving continuity is important. But with the new VisiTech, it is more reliable to make continuous lesions. How do we perform the closed protocol? We use a smart touch catheter. We pre-specify anatomically the line around the veins. We use the VisiTech with respiratory gating, with stability criteria, very important, with force criteria. We will ablate point by point with the maximum interlesion distance of 6 millimeter. We ablate until the target index value is reached, 400 versus 550. What is the power we're going to use? Can be 25, 30, 35. Most of the time we use high power because it accelerates your process. At the end, we only leave the lab when we have verified the criteria for contiguity and transmurality. Here we see the test for interlesion distance. We measure with the ruler. And the check for transmurality is just playing with the color-coded bars to see whether everything is red, etc. So that is easy. But that is the check, and we will never leave the room before the criteria are met. Here you see how it changes your workflow. We are ablating at the posterior wall 35 watts and 12 gram. After already 18 seconds, the algorithm tells you that you have reached an index of 400, and we stop application, 18 seconds only. Imagine you would have used FTI only, you would have continued and continued and continued. An example of the 35 watts at the anterior wall, 25 grams, you can stop after 36 seconds. Imagine you would have stopped at an FTI of 400, it would not have been enough. So we are clearly changing our workflow. There is an exception for reaching the index value, which is the posterior wall. If we reach esophageal temperature, it's clear that we will not target that index value. What are the results? The acute durability after close-guided PVI is close to 100%. And you can do this 200 times, 300 times in patients. You will see the veins are isolated when you finish your circle. And you can give adenosine, and the vein will be resistant to adenosine. It's objective, it's reproducible, and you can check it, it's clear. So with the closed protocol, again, it's transmurality and contiguity, we reach 98% durability. Now the big question, does this translate into freedom of atrial fibrillation? First set of data is comparative data. It's not randomized. We compared the last 50 contact force guided ablations, so just contact force using 10 to 30 gram and using FTI, and we compared them to the first 50 well-performed close protocols. I think that's a fair comparative set of data. Complications comparable in both groups. Follow-up at 12 months. Here you see the follow-up of 12 months. It's 94% in red being the close protocol, and it's 80% in the contact force guided group. Patients received a Holter at 1 month, 3 months, 6 months, and 12 months. In the meantime, we have a well-defined study population of 138 patients. They were ablated from August until August 2015. So it's a 1 year paroxysmal AF population. Typical paroxysmal AF, no structural heart disease. Low Jets-VASc score. Half of them anesthesia, 1 TIA. This is the result. Endpoint, documented AF, ATAC or flutter. Holter, 3 months, 6 months, and 12 months. Or in case of events. Follow-up, last patient was August. So you can imagine our follow-up at this point ranges from 6 months to the first patient, 18 months. 1 TIA, no steam pop, no death, no tamponade. 7 patients have reached the endpoint. AF recurrence. Vice versa, freedom of AF, 95%. It's Holter monitoring, so it's discontinuous. 4 patients had continuous monitoring via device. 4 patients show consistent elimination of atrial fibrillation after the procedure. Very important, those 7 patients all came back to the cath lab for a repeat study. 4 patients had complete pulmonary vein isolation. Only 3 patients had reconnected PVs. So this is important. 4 out of 7 patients had complete isolation of the pulmonary veins.
Mattias, just one more minute.
This is an example. Patient was ablated via the close protocol. Patient has AF recurrence. Patient is brought back to the cath lab. As you can see, veins are isolated, no left atrial scar. So then you are challenged with a difficult procedure. We induce the AFib and repeat procedure. So ladies and gentlemen, the question is clear. Are we closing the gap? Acute durability is 98% and freedom of atrial fibrillation is 94%. Are we alone? I don't think so. If you look at the data from Dr. Christopher Pierkowski, freedom of atrial fibrillation 94%, again respecting the 4 millimeter interlesion distance and using contact force catheters. So the ingredients that are similar seem to be distance, stability, and contact force. Another paper from Ito from Japan, contiguity 2 millimeter interlesion distance, freedom of atrial fibrillation seems high.
Please, Mattias.
So in conclusion,
could you
contact
please
force
finish?
guided ablation respecting index and contiguity is associated with an unprecedented high rate of single procedure freedom. This needs confirmation in a multi-center study. And the next challenge is to maintain this high durability while taking away the overshoot. Only then the unique advantage of point-by-point ablation will be exploited to its full potential. I thank you.
Thank you, Mattias. Can you hear us now?
Yeah, sure.
Are there any questions from the audience? Yes, there's one question over there. Andrea. Mattias, Andrea Sarkozy is going to present There is a microphone there.
Yeah, Mattias, can you hear me? Yeah. Okay.
Perfect.
Congratulations for this very nice presentation and results. I just have one question to ask. So why does the close protocol include burning close to the vein? What's the rationale behind that as opposed to going farther away from the vein? Why is the protocol including that?
Yeah, I will tell you, Andrea, because that is how I have been doing ablation from the start. I always follow the electrograms. But don't think that this is a tight circle. It's 12 centimeter on average. So I think many people ablate like this. Why do I feel more confident at that site? Because I avoid the posterior wall. I don't like the posterior wall. I don't like esophagus. So I feel much more comfortable when I follow the LAPV junction. That's number one. Number two is that I believe that in literature there is no study showing that you have to make big circles. Everybody is quoting the Arendt's paper, but that is clearly not the paper you should refer to. There are no data. And our data show that this 12 centimeter circle, which is not that small, again, by the way, is more than enough to eliminate paroxysmal AF. Whether it will be enough for persistent, Andrea, this is again something we will have to do and evaluate. So that is the main reason. Do I see PV stenosis? We have in those 7 repeat patients, that's the only result I can show or I can share, is we can still go with the lasso catheter to the veins. I know that is a very poor scientific argument, but we don't see any evident clinical PV stenosis.
Mattias, I have one question for you. And any lessons from the 3 patients in whom you saw PV reconnection? For example, in our experience, one area in which we see reconnections is in the roof, particularly in the roof of the right superior pulmonary vein. So we feel that sometimes if the catheter is less stable, which is something different from other parameters that we can measure, that could make a difference. What are your observations?
Very good point. I mean, you're still probably looking now at one of my slides, and because of time reasons, I did not explain it, and did not.
Now the slide is small. Can they enlarge the slide somehow?
But still, Jesús,
yeah, now we can see that. Yeah.
It's still not big enough to show you. But our 3 gaps. Because it's basically one gap in this patient was at the anterior carina, and we did not, you will be surprised and say the story is too beautiful, but at that site we did not reach transmurality according to the index. So that is number 1. The number 2 patient is a very, I remember that patient as well. There was a reconnection at the posterior-inferior left inferior PV. And there we did not respect the interlesion distance. Why? I don't know. Maybe there was esophageal or we did not pay attention when we controlled. There I had a very single gap. You see slightly more RF lesions because I know what happened. When I touched that region, mechanically it was already blocked. So then I said, oh, I know where the gap is, but I wanted to be a bit more sure. So this patient had a distance. That patient had, I think, one gap at the right superior, I can see it, right superior pulmonary vein. We remember that patient because that is the patient that was dancing on the table. He did not want to lay still, and it was under sedation rather than general anesthesia. And there we had difficulties with transmurality. So I think we can explain in those 3 patients at least the reconnection. And we think it's because we did not or could not respect the criteria.
Well, yes, last question. Dr. Pérez Castellano.
Congratulations, Mattias, for the talk. I'm asking you if you modify the flow rate during the ablation in the closed protocol, and I suppose you use the conventional temperature limits of 45, but particularly with irrigation, do you modify it?
Good point, good point. So I will tell you how the setting is in our lab. We use power controlled, and we have a pseudo power control because we look at the temperature. And the moment the technician sees 41 degrees in our lab, we reduce the power. But it's power controlled, so it means that I give the power from the first second. If it's set to 35 watts, you will see 35 watts. That's different from temperature controlled. But it's not completely power controlled because we are still looking at the temperature. I don't like temperatures that exceed 41 degrees, then I'm afraid of steam pop. That is how we have been ablating from the very start. So it's power controlled. Now the irrigation is at 17 cc. That is for historical reasons with the Stocker pump, you know, it's 17 cc. But when I want to deliver 35 watts and I feel that temperature is rising too much, I can easily ask the nurse to increase up to 30 cc. And then I will be able to work faster and to deliver the 35 watts. So yes, we play with the irrigation rate.
Thank you.
Thank you. Thank you, Mattias. Thank you very much for your talk and the beautiful discussion.
I'm happy for this. Bye-bye.
So we move on to the next speaker, that is Dr. Serge Boveda. And his topic now is how to perform pulmonary vein cryoablation in case of vein to balloon mismatch. Dr. Boveda.
Hello. Bueno, antes de empezar, muchas gracias para esta invitación, otra vez más. Gracias a Nicasio, gracias a vosotros. Voy a tener que hablar inglés, será más difícil seguramente un poco para vosotros, pero sobre todo para mí será más complicado. Pero bueno, vamos a hacerlo en inglés. Okay, so I will try to show you how we can act when there is a vein-to-balloon mismatch. But most of all, I will try to convince that in fact, because the way we are working with this device, there is very few vein-to-balloon mismatch with cryoablation. These are my disclosures. So you know that cryoablation in this survey from ERA of 2012 was very few around Europe. It was around 13% of these more than 1,000 patients that were treated for AFib ablation. At the present time, it's more in the majority of the European countries, more than 30% of AFib ablation that is done with cryo. In our institution, we have more or less 1/3 of patients now that are treated by cryoablation of the total atrial fibrillations that we treat every year. But if we are looking for about the paroxysmal, in fact, it's nearly half of the paroxysmal that are treated by cryo. This will certainly increase in the next years. Why? Because we believe, and I completely agree with Angel, that we of course need the radiofrequency to treat certain atrial fibrillation, namely the persistent. But by earning a little bit time, by treating paroxysmal, we can treat maybe more persistent atrial fibrillation. So we are doing radiofrequency every day, but we believe that cryo will also improve for the paroxysmal. To be a technique of future, a technique needs to be, of course, efficient, safe, reproducible, quite simple and easy to learn, of course, cost-effective, but I also believe that a technique to be really efficient and have future needs to be for all patients. It needs to be effective for all patients. And this was my first concern while using cryoablation. Was it efficient for the vast majority of the patient? And I was, like you, a little dubious about this point. We know that since the beginning, when we are looking to the pulmonary veins, that each patient is a different patient concerning the PVs. Every anatomy is different for every patient. And if we think that a normal distribution is 2 veins on the right and 2 veins on the left, more than 30% of the patients are not in this normal distribution in the reality. Even more, when we are looking inside, there are difficult sized to reach, namely the reach, for example, which is difficult to ablate even by radiofrequency. We know that to go here needs a lot of experience and a lot of skills. And this, of course, should be the same with a cryo. When you have a common monostomy, of course, it is oval, it is not spheric, and we can think about the effectiveness of a spheric balloon to treat this kind of veins. In the same problem is for the right inferior pulmonary vein, that sometimes is very posterior and very little, and with a big balloon it should be difficult to reach. So, since the beginning, we know that to avoid, and it's a little bit different to what we have heard just right now, to avoid this kind of difficult anatomies, it was advised to try to make large circles, wide, large isolation of the PVs 2 by 2, either by radiofrequency and a 3D mapping system, but also it can be done, as you can see here, not very well, but the balloon in fact is here, in fact in the middle of the vertebra. Here you can be outside, of course, you have to be, not you can, you have to be outside of the veins with a big balloon in order to treat it. And when you inflate the balloon and when you are injecting the vein in order to see that you are occluding the vein, you can see very easily that the balloon is at least twice the dimension of the vein. So you can suppose that your lesion is much bigger than the vein you are treating. The lesion is in fact very antral when you use the big balloon, of course. I thank Julian Schoen to let me this slide, which is very, I believe it's very nice to see that when you are exploring the lesion that you are doing with a point-by-point 3D mapping radiofrequency ablation, and when you are doing a 28 millimeter balloon, of course it's not the same patient, but the volume of the atria are comparable. You can see that in fact the resulting lesion, the scar that you have after the treatment is very comparable between the two techniques. And this is a hot patient that we did last week in Lisbon with Mario Oliveira. It was a very interesting case of a redo patient that was treated about 1 year before by radiofrequency and had a recurrence. We did a high-density voltage map with the pentarray, which was very interesting because we could see, in fact, the inputs and where we had the recurrence for each vein, and we observed that the only vein that was still disconnected was the right inferior. The other 3 veins was, in fact, reconducting. We did, in the same procedure, of course, a cryoablation of not the 3, but the 4 veins, because I believe also that with the balloon we can treat also substrate. So we did again one application, only one application, because now we are using dosing of the 4 veins, and then we redid a map after the cryo balloon. When you are looking to anterior view, it's not very impressive because, of course, you have more lesion. We have disconnected the vein, indeed, but you can see that, okay, the scar is bigger, but it's not very impressive. But remember that the pulmonary veins are not anterior, they are in the posterior wall. And when you're looking to the posterior wall, then you see that this is before ablation, after the redo of the first procedure of radiofrequency, and this is after the cryo balloon. And here you can see that, especially for the right veins, the lesion is wide, it's big, and it's nearly joining it here at the bottom of the posterior wall. In fact, my first impression was to say, wow, where is the esophagus? Because we are occluding maybe quite all the posterior wall. This is confirmed by this very nice paper, I believe, from Königsberg, that show that after using the 28 millimeter balloon, you can see that you can treat more or less, here it's in blue, the right veins and the left veins. You can treat more or less more than the two-thirds of the posterior wall with a 28 millimeter balloon. This means disconnection of the vein, but of course not only. So what is our policy? At the present time, and since many years now, we don't do, because I believe that a technique that you have to treat a very few proportion of the patient is not a viable technique for the future. So since nearly the beginning, we don't do a patient selection. Only, of course, we treat with cryoparoxysmal, not all the AFib. The only selection that we are doing is on the type of atrial fibrillation. But for the paroxysmal atrial fibrillation, we don't do patient selection. We use only, since the beginning, the 28 millimeter balloon, and it's now the case for, I believe, all the centers. We do for all patients a pre-procedural imaging, CT scan, not to select again, but to guide the procedure, because we believe that it's really important to know before the operation what you will find and where you will go. Do you have a common trunk? Yes, no. Do you have 3 veins from on the right, for example? Yes, no, because then you go directly to the spot, and I believe you're safer and you're more efficient at the same time. And because that we don't do PV angiograms, because it's not needed. We know exactly where we have to go. So there are many tips and tricks, and these are ones that we can use and we use every day. They are described since many years by Julian, again, showing, for example, the hockey stick technique that can help for very posterior veins. It needs a little skills, but it's not really extremely difficult to do after a learning curve. There we use also quite often the pull-down technique, namely for the right inferior pulmonary vein. We begin to freeze on the roof of the vein. We can leave sometimes, when it's difficult to occlude the vein, a little gap in the posterior part of the vein. And once we are begin to freeze, then we do a gentle pull-down in order to close this gap and then to finally disconnect the vein. But these are tips and tricks that you can learn. It's true for all the techniques we are doing. To implant a pacemaker needs also tips and tricks. Which technique doesn't need tips and tricks? So the experience will do the work. You need tips and tricks to do a 3D, don't you? Of course you do. So one thing that I believe is extremely important, we are speaking about the new generation balloon. Of course, the advanced 28 millimeter balloon, it's no doubt, it's much more powerful than the previous one. It works extremely well. But I believe that the most important evolution is that now we are not working like hemodynamists. We are really working like EPs with the AFib catheter that is measuring, that is looking at the pulmonary veins at the real time, and you can monitor. You don't have the contact force, but I think that it's even better than the contact force, because you can monitor at the real time what you are doing. Are you efficient on the vein or not? If you are efficient, you can follow the application. If you are not efficient, you just stop and don't give a full application. So the AFib catheter, and really fight for that, because people is saying, yes, I don't see the PV potential. The fellow say, okay, Serge, I don't see the PV potential. I say, yes, you have to see the PV potential. There are PV potential, you have to find it. You have to fight to find it. Maybe work 2 minutes more to maneuver the AFib, but it's really important to find the PV potential. Why? Because when you obtain this kind of registry that you can see, and one thing that is very important with the AFib is to look all the electrograms, not 1, 2, and then 3, 4, and then you have to look for 1, 2, 2, 3, 3, 4, 4, 5, because you have a circumferential activity of the vein. And you can see very clearly that in this case, for example, while ablating, you are separating the PV potential and finally disconnecting. If you see that, you can go on, it works. You don't need contact force. That means that you are disconnecting, that it works. If after one minute or 2 minutes you have nothing, it doesn't work, you can stop. And in our experience, This is real life for everybody who is coming. They can see that for all the cryoablation, we are looking for the PV potential. In most of the case, we can find the PV potential doing some kinds of maneuvers like here by flipping the achieve towards the tip of the balloon, because of course when you're putting the achieve very far inside the vein, you won't see anything like here, for example, but when you are trying to find, then you can find most of the time the PV potential. Sometimes you don't see well the PV potentials, but you are assessing the exit conduction, and you can see that, like here, that we are pacing inside the vein, we are capturing the vein, and then you can see the changing in the P wave. We are capturing the left atrium while freezing, and you can see the increasing of the distance between the spike and the QRS, and finally we lost the capture of the left atrium, and we obtain here an exit block, and so then we can assess the entrance block after, and we can see that this vein is finally disconnected. Doing this kind of maneuvers, we can obtain around 90%. I have to be fair with you, it's not 100, but we can obtain around 90% of PV assessment, real PV assessment. And what we observe, and it is observed by everybody doing cryo, is that when it's efficient, it's quickly efficient. We obtain a PV disconnection in real time, usually in less than 1 minute. So, again, if you are in a difficult vein, posterior, difficult to occlude, and you see that after 90 seconds you don't do anything, you stop. It's not good. You have to replace the balloon, replace the achieve catheter. You have to work in a better way in order to disconnect sooner the vein you are treating. Coming back to the anatomy in a few minutes, I see I have 5 minutes still. So we will speak, of course, there are difficult anatomies. I agree with you. And we face sometimes difficult situations, like here, for example, a very low common trunk, like additional veins. But the solution is quite obvious, in fact. When you have, for example, a right additional vein like here, in the middle, what happens? If you measure, and you ask to the radiologist to measure the distance between the roof and the bottom of the roof of this vein and the bottom of this vein, in fact, you have around 38 millimeters of measurement of this distance. If you put your balloon in the superior vein and then the balloon in the inferior vein, you add 28 millimeters plus 28 millimeters, it's much more than 38 millimeters. So by only doing 2 applications, and again, remember the picture we did in Lisboa last week, you can see that the lesion is much wider. You don't need to go specifically in each branch, because in fact you are treating the antrum. So by giving just 2 applications, you are treating, by the way, the additional vein that you have in the middle. What about a common trunk? It's true that the common trunk needs a little bit more skills. Sometimes you have common trunks that are around 28 millimeters, so the size of the balloon itself. What is extremely important is not to push too much the balloon. And with a newer balloon, which is, again, very powerful, you don't need to push very hard on the balloon. You just need to fix the balloon on the roof of the common trunk and then do a pull down in order to close the posterior gap, and then you obtain this kind of images that it was a common trunk of 25 millimeters, a little less than the dimension of the balloon, but this is, to be honest with you, a redo patient. But it's a redo patient, not from the veins. It was a patient that we did with cryo, I don't know when, but maybe many months ago, and he had recurrences. I asked to one of my radiofrequency colleagues to do this redo, because I thought that there was no reason not to be effective with the balloon. So he did first a voltage map. I asked him to do a very nice voltage map. He told me, yes, the veins are disconnected, and in fact, he found it fragmented potential zones in the region of the ridge. Okay. This was by random that we have published a few weeks ago a paper in Europace looking this question of the anatomy of the veins. And in fact, it's not randomized, it's really a not randomized trial, but we took more than 300 patients in the radiofrequency group and in the cryoablation group. And we looked for the anatomy. We had about 20% of common osteum in each group. We had about 20% of additional veins in each group. And we could observe two things. The first thing is that cryo and the radiofrequency work the same way. They are equal. We could see also, and it's more important, that for each subgroup with each technique, there is no significant difference in the results. And when you are analyzing the curves more cautiously, you can see that for the left common ostium, the additional veins, or the normal distribution, in fact, the success rate for both techniques is around 80% at 1 year. So there is no significant difference. It's only paroxysmal. Remember, we are speaking about paroxysmal here. This is a paper that is not still published, but it will be published in the next weeks. And I believe it's also a very important point I want to share with you. If you are looking at the different volume centers and you are comparing both techniques, here you have 5 centers. It's a French registry with a very big volume center and lower volume centers, and namely centers of around 100 ablation per year. We compare radiofrequency and cryo results at a little bit more than 1 year, and what we could see is that the results for cryo were exactly the same independently of the volume of the center. And I believe that this is this is real life, and it's really important to share that, is that the results for cryo are the same. And for radiofrequency in the big volume center, it's exactly the same results that with the cryo. No doubt, it's the same. But for the lower volume centers, you can see that the standard deviation is a lot. It's going from 40% of success at one year to 80%, which is very different for this technique. The 3 points that were significant in multivariate analysis, and I'm finished now, I see a few seconds, is the volume of the center. If you are doing less than 100 ablation per year, so there is a risk of having less good results. If you use the contact force, it's better, and if you use the cryo by itself, you have more chances to obtain better results. And this is the reason why in the global cohort, and this is different from fire and ice, of course, but in the global cohort, in this study of different volume centers, the cryo is coming before the radiofrequency in terms of success rate, because we're merging very different kind of centers. So, to conclude, in our center, and I believe that for cryoablation, we don't have to think about patient selection. We are not doing patient selection since ever, I have to say, and it works. For the specific anatomy, I agree with you that it can be difficult, but it is also difficult for radiofrequency, not only for cryo, and you need maybe more skills to be more efficient with radiofrequency than with cryo. And of course, we have to use only and always the 28 millimeter balloon. We have nearly never used the 23 millimeter balloon, and I believe that the reproducibility of this technique is good, specifically for special anatomies. I thank you very much.